Hello, everyone.
Hallo Thomas.
Ciao, Franz. Da können wir jetzt Schweizerdeutsch, hä?
Ja, genau.
Der Christoph versteht dich so.
Gut.
Schön, dass du da bist.
Ja, du, ich komme nicht nach mit Lesen, was du alles schreibst. Da denke ich, soll ich mir mal auf die Art und Weise einen Überblick verschaffen.
Okay, damit müssen wir, glaube ich, aufhören. Da.
Okay, so everyone from the waiting room has joined. So we will start. So, dear attendees, thank you very, very much for joining us today. Today is the first talk of a new four-part series by SPR focused on expansion of skills in psychotherapy and integration of new advances. The purpose of the series is to introduce new skills and methodologies that are being introduced into psychotherapy treatment and psychotherapy research. The series has been organized with the great help of Professor Christoph Flückiger and Professor Sigal Zilcha-Mano, who have personally, with much thought and care, chosen the speakers for this series. So a big, big thank you for both of them for helping organize this series. Today's speaker is Professor Thomas Berger. He is a professor of clinical psychology and psychotherapy at the University of Bern and a licensed psychotherapist. For over 20 years, he has researched disorder-specific, tailored, and transdiagnostic internet-based interventions. His work focuses on treatment outcomes, active components, and mechanisms of change, as well as the role of therapists and the therapeutic alliance in digital interventions. He has received several awards for his work, including the Outstanding Early Career Research Award from the Society for Psychotherapy Research from SPR in 2014, and the Interdisciplinary Swiss Science Prize Marcel Benoit in 2021. Today, he will be giving a talk titled Internet-Based Interventions from Efficacy to Active Components and Clinical Applications. We are all very excited for this fascinating talk and for the official opening of this series. Before we begin, it is important for us to mention that the talk is being recorded and will be later available on the SPR YouTube channel. In addition, please make sure to keep an eye on the SPR calendar, where you can learn about future events as well as the future parts of this series. And lastly, a quick reminder that the registration to the annual SPR conference in Osaka, Japan has begun, and we would be very glad to see you all there this year. Links to the YouTube channel, the SPR calendar, and the annual conference are now in the chat. So thank you all very much for listening to this introduction. We will now start the presentation. I will just mention quickly that the questions will be taken at the end. So if you have any questions throughout the presentation, you can leave them in the chat and they will be addressed later. Thank you all very much.
Hello, everyone. Can you see the presentation and also hear me? So first of all, thanks a lot for the invitation and also the very nice introduction and for organizing this webinar. It's really a pleasure to be here today and to talk about internet-based interventions. So I start. So let me briefly walk you through what I'll cover today. After a brief introduction and the definition of different type of internet interventions, I'll summarize what we know about their efficacy, and then I'll take a closer look at which treatment components drive outcome and how. And finally, I'll briefly touch on how internet interventions are implemented across different countries. So as a brief introduction, I would like to mention that I'm fully aware that internet interventions are not always the most popular topic among psychotherapists. About 10 years ago, Johanna Schröder conducted several studies on attitudes towards internet interventions, both among patients and psychotherapists. And the findings were quite clear. Patients were generally open and interested, and they valued the advantages of internet interventions such as accessibility, flexibility, and anonymity. On the other hand, psychotherapists were more skeptical. They had concerns about the therapeutic alliance, treatment quality, and overall effectiveness. At the same time, we also observed an experience effect. Attitudes tended to be more positive with experience. The more therapists actually used these interventions, the more positive their views became. Now, as you all know, things changed with COVID-19. During the pandemic, many therapists suddenly had to switch to online formats, and this also shifted perspectives. There's a well-known editorial by Tim Wind and colleagues that describes COVID-19 as a black swan for mental health care, a rare and unexpected event with major consequences. And this is not just an impression that there was a change in the perspectives of therapists. There is also empirical evidence supporting this shift, specifically for video-based therapies. I mean, we all observed that therapists who had previously been quite skeptical rapidly adopted video-based treatments almost overnight. And most of them realized that it works. But it wasn't only video-based therapy that gained traction. There was also a clear increase in the use of internet-based self-help programs during COVID-19. For example, together with Guy Bodenmann from the University of Zurich, we made Parlife Online, a self-help program for couples experiencing relationship difficulties, freely available during the COVID-19 pandemic. And what you can see in this figure is the number of registrations in 2020 during the COVID-19 pandemic. And as you can see, registrations increased dramatically in March 2020, right at the beginning of the first lockdown in Switzerland. This was the first time this was actually the time when many couples were suddenly confined to their homes, spending much more time together than usual. And interestingly, these numbers only started to decline again once restrictions were eased, for example, when hairdressers and garden centers reopened. As we have seen, there are different types of internet interventions, so let me start by briefly introducing them. I'm doing this as the distinction of different types of internet interventions is important because each type comes with its own strengths and weaknesses, and we also have different levels of evidence for each of them. First of all, and I just touched on this, the internet can simply be used as a communication medium, for example, in treatments delivered via video conferences, chat, or text-based messages. As I just mentioned, video therapy experienced a major breakthrough during the COVID-19 pandemic. However, the evidence is still somewhat limited. There's not much research on video therapy, and it will not be the main focus of my talk today. The same is true for email and chat-based interventions. Also, these formats have received relatively little research attention so far and are more commonly used in counseling settings, for example, in crisis support, rather than in psychotherapy. An important reason why email and chat have not seen broader uptake in psychotherapy is efficiency. Writing typically takes more time than speaking, making these formats more time-consuming for both patients and therapists. Beyond being a communication medium, the internet can also be used, as you all know, as an interactive information medium. And regarding internet interventions, we have fully automated, self-guided web-based programs or smartphone apps that patients work through on their own. This is often referred as unguided self-help, and this term unguided self-help is often to distinguish this term from guided self-help, where some form of therapist support is provided. In a guided self-help, patients work through a structured online program, but with some additional support from a therapist. This support is usually brief and provided on a weekly basis, usually in the form of text-based feedback via messaging. It mainly focuses on motivating patients, supporting adherence, prompting tasks, and answering questions rather than delivering full psychotherapy. This format is sometimes also referred as minimal contact therapy, reflecting the relatively low level of therapist involvement, typically around 10 minutes per patient per week, which also makes this an efficient approach. And finally, there are blended treatments that combine traditional face-to-face sessions with online components. Patients still meet their therapist in person, but for instance, between sessions, they work with a self-help program or an app. So in contrast to guided self-help, where support is provided remotely and typically in a brief text-based format, blended treatments include regular face-to-face contact with a therapist. Now, when you look across these different formats, it becomes clear that each comes with its own strengths and limitations. For example, fully self-guided programs are highly scalable and very easy to access, and they don't require any therapist time. At the same time, patient safety can be of concern, as these programs are not suitable for individuals in acute crisis. They may also be somewhat less effective than interventions that include therapist support, but I'll come back to that later. So at the center of many internet interventions are self-help programs. These are used, as I just said, in unguided and guided self-help formats, but also play a key role in blended treatments. So I think it's worth taking a closer look at them. I should briefly mention, sorry for that, I should briefly mention when I talk about self-help programs that I'm referring here only to evidence-based programs and apps, not the many untested apps available in app stores. Most of the evidence-based self-help programs are based on cognitive behavior therapy, and that's why the term ICBT, which stands for Internet-Based Cognitive Behavioral Therapy, is commonly used in the literature. However, the field has grown rapidly over the past 20 years, so we now also see programs based on other approaches such as psychodynamic therapy, interpersonal psychotherapy, acceptance and commitment therapy, mindfulness-based approaches. There is also an app for borderline patients based on schema therapy. So there are many other approaches now delivered via self-help programs. A second key feature is that these programs are typically structured into modules, sometimes also called sessions or lessons. This modular format is probably the most common. However, there are now also shorter treatments such as single session interventions with just one module, or in Australia, they developed and tested so-called ultra brief interventions with up to 3 modules. On the right-hand side of the slide, you can see an example of typical modules in a CBT-based depression program, including behavioral activation, cognitive restructuring, and mindfulness. Participants are usually asked to complete 1 module per week, mimicking in some way the structure of weekly face-to-face sessions. In guided self-help, therapists often send briefly weekly messages to remind and encourage participants to start the next module. Then regarding content, the programs usually include psychoeducation delivered via text, audio, or video, along with practical exercises such as relaxation techniques or activity diaries. Many programs also include regular symptom monitoring, where participants complete questionnaires and receive feedback on their progress over time. Now let me move on to the effectiveness of internet interventions. I have to say I could easily spend hours on this topic because the field has grown tremendously over the past years. There are more than 400 randomized controlled trials now. In fact, for some conditions, we now have more studies available than in traditional psychotherapy research. So before I go into effectiveness, I'd like to briefly give you an overview of the target populations in this field in research. So for all these conditions mentioned here, there are randomized controlled trials. And I've divided this into 3 parts. First, mental disorders as defined in diagnostic systems. Here, most of the research has focused on common mental disorders like depression and anxiety disorders. But as you can see, the field has really expanded. There are now studies across a wide range of conditions, including psychotic disorders and borderline personality disorder. A second important target group are patients with somatic conditions. This includes, for example, internet-based interventions for chronic pain, tinnitus, or sexual health problems, but also for chronic medical conditions like cancer or cardiovascular disease. What these interventions typically have in common is that they don't target the medical condition itself, but rather the psychological distress associated with it. A third group are problem-specific targets. So here we are not talking about formal diagnosis, but rather about specific problems that people identify with, things like perfectionism, loneliness, or stress. Many of these can be understood as transdiagnostic vulnerabilities, meaning they cut across different mental disorders. This is really an emerging field within internet interventions, and also an interesting one because many of these interventions were actually first developed and tested in digital formats. I should say that this field, but also the field as a whole, has very much been driven by the Swedish group around Gerhard Andersson. They have done many studies now on problem-specific targets. Now, let me turn to the effectiveness of internet interventions, focusing on common mental disorders in adults. This slide summarizes findings from a recent meta-analysis by Harrer and colleagues, which I think is very informative because it includes only randomized controlled trials with confirmed diagnosis. That's important because many studies in this field rely on symptom levels rather than formal diagnosis. But this meta-analysis here covers 8 common mental disorders. And as you can see, the largest evidence base exists for depression, but there is also a substantial number of studies for insomnia, social anxiety disorder, PTSD, panic disorder, generalized anxiety disorder, and OCD. All effect sizes shown here are compared to inactive control conditions, primary waitlist, or care as usual groups. What we observe is that internet interventions show large effects for several anxiety disorders and for insomnia with HSG values above 0.8. For depression, PTSD, and OCD, the effects are in the moderate range. Let me zoom in a bit on depression, although we see very similar pattern across other disorders. The effect size shown here, HSG, is based on comparisons with inactive control groups, and it's important to keep in mind that the type of control group really matters. As you know, in general, studies using waitlist controls tend to report higher effect sizes. In contrast, when internet interventions are compared to care as usual, the effects are smaller, but still clearly meaningful. In this meta-analysis, the effect size for depression drops to around 0.41 when only care as usual is used as the comparison. And we see the same pattern in other meta-analyses. For example, Moshe and colleagues included a broader range of studies, also with participants who had elevated depressive symptoms rather than confirmed diagnosis. Their results show moderate to large effects compared to waiting list controls and small to moderate effects when compared to care as usual. Let me zoom in a bit further on one large randomized control trial on a self-help program for depression. In this study, more than 1,000 participants received either care as usual alone or care as usual plus a self-help program for depression. And care as usual in this trial, conducted in Germany and Switzerland, was quite substantial. About half of the participants received antidepressant medication, and roughly 1/3 received psychotherapy. What you see here are outcomes at post-treatment after 3 months. That was the primary outcome, and then follow-ups at 6 and 12 months. For the primary outcome, depressive symptoms, we found small to moderate between group effects at 3 months and also small to moderate effects at 6 months with Cohen's d of 0.39 and 32. And these differences were also statistically significant. However, by 12 months, the difference between the groups had largely disappeared, also because the control group gradually caught up. Then beyond comparisons with inactive control groups, there are also meta-analyses that only include studies with direct comparisons between guided internet interventions and face-to-face psychotherapy. One of the most recent examples is this meta-analysis by Eric Hedman and colleagues, which is often cited. In this review, 31 randomized control trials were included, all directly comparing therapist-guided internet interventions with face-to-face treatments. And the key finding is that there is no significant difference in effectiveness between the two formats. The pooled effect size is essentially zero. And that's why you'll often see the conclusion in the literature that guided self-help can achieve outcomes comparable to face-to-face psychotherapy. Personally, I would be somewhat cautious with these conclusions for several reasons. From my perspective, there are still hardly any large-scale studies directly comparing the two formats, and I'm not entirely sure whether we should make this comparison at all, as usually different patients seek out face-to-face versus internet interventions. And that's also a question in research. Are patients in studies on internet interventions comparable with patients in face-to-face studies? And there seem to be some differences. For example, in depression, patients in internet trials tend to show fewer prognostic risk factors, such as lower severity or fewer comorbidities. However, for social anxiety disorder, we see an opposite pattern with, for instance, higher levels of interpersonal problems in internet-based interventions. So the question is not resolved yet from my point of view. As I said, we should probably not focus too much on direct comparisons with face-to-face therapy, because one of the goals of internet interventions is indeed to reach people who would otherwise not seek or receive traditional psychotherapy. But overall, we now have a large and quite robust evidence base for adults, and the effectiveness of internet interventions is well established. What is a bit surprising, however, is that there are still far fewer studies in children and adolescents, as you can see here, with only a small number of trials for anxiety and depression in a recent meta-analysis. I think by looking at these numbers, we can say that overall, internet interventions also look promising for younger populations, but the evidence base is still much more limited compared to adults. So we've seen that internet interventions work. The next question is, what are the active ingredients? Which components actually drive change, and how do they do so? One of the key questions we have been studying for more than 15 years now is whether therapist support is actually needed. In other words, are self-guided programs sufficient on their own, or does adding therapist guidance make a meaningful difference? And I have to say upfront, even after all this time, we still don't have a definitive answer, because the findings are somewhat mixed. In the following, I'll show some results for depression, where I think there is evidence that guidance and contact with therapists actually improve outcomes. I'd like to start with a meta-analysis by Tobias Krieger, looking at how the effects of internet interventions for depression vary depending on the level of professional support. And in this figure, first, there are studies with no human contact at all. neither before the intervention, for example, for his assessment, nor during the intervention in terms of guidance. That's the first group here, labeled none. And then you see the effect sizes for each study. Then we have studies where there was contact before the intervention, for example, a diagnostic interview, but no ongoing guidance during the treatment. That's the second group before the treatment. And what we can see here is that even this initial human contact seems to increase the average effect size. Overall, the largest effects are found in studies where there is contact both before and during the interventions. So a combination of initial assessment and ongoing guidance by a professional. That's the last group here. So overall, contact with therapist and guidance seems to play a role regarding outcome. Interestingly, another recent meta-analysis by Terhorst and co-authors suggests that therapist contact becomes even more important as symptom severity increases, meaning that more severely depressed patients seem to benefit specifically from professional support. There are actually not that many direct comparisons between guided and unguided treatments. In our group, we have conducted several randomized control trials directly comparing guided with unguided treatments, and this is the most recent one. And what we found in this randomized trial for individuals with elevated depressive symptoms is a significantly stronger reduction in symptoms when the program was guided compared to self-guided approach. And the advantage of such direct comparison is that other factors are held constant, most importantly, the self-help program itself. So we can really isolate the effect of guidance. The next question we asked in this study was, how does guidance improve outcomes? And in a mediational analysis, we identified two mechanisms. The first one was adherence to the self-help program. With guidance, participants were simply more likely to stay engaged, complete the modules, and actually follow through with the program, and that in turn led to better outcomes. And this is very much in line with what we already know, especially unguided programs often struggle with low adherence, and guidance seemed to address exactly this problem. This adherence problem raises an interesting question. If guidance works by increasing engagement and adherence, are there other ways than human guidance to achieve this? And one possible answer comes from newer delivery formats such as chatbot-based interventions. As you all know, there are now also interventions delivered via chatbots. Earlier work focused on rule-based chatbots, but recently we see systems based on Gen AI, such as Therabot, which you can see here. And with these chatbots, content is no longer delivered as static text, videos, or audio, but in a dialogue-based format. And an idea behind this is that the conversational delivery, similar to what we know from ChatGPT, may enhance engagement and outcome. In the largest study I'm aware of using Therabot, engagement was indeed quite high. Over 8 weeks, participants with depressive anxiety and eating disorder symptoms, so this was a rather transdiagnostic approach, sent on average around 260 messages to the chatbot. And in the randomized control trial with 210 participants, the chatbot led to significantly greater symptom reductions compared to a waitlist control group with moderate to large effects on depression, anxiety, and eating related symptoms. To my knowledge, there is no direct comparison yet with guided self-help, but the effect sizes are in the similar range. So what I want to highlight here is when we talk about differences between unguided and guided interventions, these differences might disappear with newer delivery formats like chatbots. But let me come back to these questions of how guidance improves outcome. Besides adherence, a second pathway through which guidance influenced outcome in our study was the therapeutic alliance. We found that agreement on goal and tasks, as well as the bond with the study team, were stronger when guidance was provided, and this alliance in turn was associated with better symptom outcomes. Now, it's possible that chatbot-delivered interventions could also foster some form of alliance. There is actually research showing that even with self-help programs, users can develop a sense of alliance that is related to outcomes. But in this talk, I'd like to focus a bit more on the role of the therapeutic alliance with human therapists in internet interventions. And here I'd like to say that there is a growing body of research, including several reviews and meta-analyses on the therapeutic alliance in internet interventions. And what these reviews find is first that the alliance with online therapists is rated by patients just as positively as in face-to-face settings, even when contact is minimal or only written. And the second finding is that similar to face-to-face therapy, alliance is also related to treatment outcomes. A recent meta-analysis by Christoph Flückiger found small to moderate associations comparable to traditional therapy. Interestingly, in this meta-analysis, subscale analysis suggests that agreement on goals and tasks may be more important than the emotional bond, indicating that the alliance in internet interventions might be somewhat more focused on collaborative aspects, agreement on goals and tasks. Despite these findings, I think we should ask the question whether the therapeutic alliance is really comparable between internet and face-to-face interventions, and I just published an article on that. There may be methodological reasons why patients rate the alliance just as positively in both formats. We once conducted a qualitative follow-up study and asked participants why they rated the alliance so highly in a guided self-help interventions with only minimal text-based contact with a therapist. And some of them said things like, given that the contact was only brief and text-based, the alliance was actually very good. So in other words, they rated the alliance as high because their expectations were quite low, and these expectations were met. I sometimes compare this to hotel ratings on booking platforms. If you rate a one-star hotel as very good, say an 8.2, you're doing that relative to your expectations of a one-star hotel. But that does not mean the quality is comparable to a five-star hotel, also rated with an 8.2. So also here, I think we should be careful with direct comparisons. I also think that there are certainly some differences in the therapeutic alliance when interventions are delivered at a distance, especially in text-based formats, compared to face-to-face settings. So let me say just a few words about differences in text-based online versus face-to-face communication. First of all, I think it's quite clear that something is lost in text-based communication. There is physical distance, the communication is less rich because nonverbal cues are missing, and there's also less immediacy, especially in asynchronous formats. At the same time, we should also see that some of these limitations may be partly compensated. For example, in text-based communication, patients often have to put their emotions into words for more explicitly, simply because these cannot be conveyed through tone of voice or facial expressions. And this more explicit verbalization may in itself already have a therapeutic effect. In addition, we often observe what is known as the online disinhibition effect, meaning that people tend to be more open and sometimes more willing to share personal or intimate experiences than they would in face-to-face settings. There is also a nice old theoretical explanation for this greater openness in online settings, the so-called intimacy equilibrium theory developed in social psychology. Think about the situation like the one in the picture. You're standing in an elevator with another person very close to each other. What you typically don't do is look directly into their eyes because that would feel too intense, too intimate for that level of physical proximity. So the idea is that we constantly regulate intimacy across different channels, like physical distance, eye contact, and verbal disclosure to keep intimacy in balance. And if one channel is reduced, like in online therapy, where there is physical distance and sometimes no visual contact, people can allow themselves to share very personal or intimate thoughts in writing. But let me come back to the question of which treatment components actually drive outcomes and how. We've seen that guidance and the therapeutic alliance seem to play a role, likely also by increasing adherence to the intervention. But there are also other contextual and common factors that contribute to outcome. For example, having a proper diagnostic assessment before the treatments, as we have seen, but also patients' expectations. I'm not showing this, but there are several studies now showing that more positive expectations are associated with better outcomes, just as we know it from face-to-face therapy. Another key factor is self-efficacy. I mention this because it is specifically relevant in internet interventions where patients work more independently and gain the experience that they can manage their symptoms on their own. A recent meta-analysis by Berger and colleagues showed that self-efficacy explains on average about 32% of outcome variance in mediation analysis. Beyond these more general and common factors, an important and, from my point of view, very interesting question is whether specific components within a self-help program actually drive therapeutic change. In other words, does it matter which techniques we include in these self-help programs? Now, an advantage of online interventions is that we can systematically vary and test individual components or modules in a very controlled way. And we did this recently using a self-help program for social anxiety disorder that has already shown effectiveness in several studies. The program is based on CBT and it includes mainly 4 modules such as psychoeducation, cognitive restructuring, attention training, and exposure. Our key research question here was can we identify active components? That is, can we identify those modules, those treatment elements that drive therapeutic change? And we tested this using a randomized factorial trial. So instead of comparing just 2 groups, we systematically varied the 4 treatment components: psychoeducation, cognitive restructuring, attention training, and exposure. This resulted in 16 different conditions, covering all possible combinations of these modules. Each component was included in half of the conditions. So, for example, cognitive restructuring was present in 8 out of the 16 conditions and absent in the other 8 conditions. The same applies to all other components. And that's really the key idea of this design. If we want to know whether, say, cognitive restructuring is an active ingredient, we simply compare all participants who receive it with those who did not. So we're not comparing 16 separate groups one by one. Instead, we isolate the effect of each component across all conditions. In the field of online interventions, there have been several factorial trials in recent years, so this approach is becoming increasingly common to better understand what actually works. This slide shows the participant flow of this study. Just to give you some background information, we recruited participants online and through media coverage, so it was a self-referred sample. In total, around 4,500 people visited our study website and 530 participants gave informed consent, completed the baseline assessment, and took part in the diagnostic interview. Most exclusions after the diagnostic interview were due to participants not meeting criteria for social anxiety disorder, and in the end, 464 participants were randomized into the 16 conditions. So this was quite a large study conducted by Diana Sipka and Rodrigo Lopez at the University of Bern. And here are a few characteristics of our sample. The mean age was 31 years. About 3/4 of the participants were female. 30% had a university master's degree, and more than half met criteria for an additional mental disorder besides social anxiety disorder, according to the diagnostic interview. And here are the main findings. For psychoeducation, we found that conditions including this component were significantly more effective than those without it. At post-treatment, the between-group effect size was 0.39. By follow-up, the effect size had decreased somewhat as participants in the conditions without psychoeducation had partly caught up. Regarding psychoeducation, Rodrigo Lopez also tested a predefined mediation hypothesis. We expected that its effect on social anxiety symptoms would be mediated by an increase in knowledge about SAD. To test this, we included the knowledge test, which participants completed after 4 weeks. And what we found is that psychoeducation increased knowledge at 4 weeks, and this increased knowledge was associated with lower social anxiety symptoms at 8 weeks. So overall, the mediation hypothesis was supported. And while it may seem quite intuitive that psychoeducation increases knowledge and that knowledge is helpful regarding symptom reduction, there are actually not many studies that demonstrate this mechanism. In contrast to psychoeducation, we found no specific effects for attention training or cognitive restructuring. Between group effect sizes with or without these components were essentially zero. So quite simply, it did not matter whether these components were included or not. And based on this, we are now testing in a follow-up randomized controlled trial whether we can streamline the intervention by removing these components comparing a shorter with a longer version of the program. Another component for which we found a specific effect similar to psychoeducation was exposure. Participants who received the exposure module improved more and they improved faster. I won't go into all the details here, but in the mediational analysis, Rodrigo Lopez showed that one key pathway was actually a reduction in negative cognitions. So interestingly, while cognitive restructuring itself did not show a specific effect, receiving the exposure module was associated with changes in negative cognitions, and changes in negative cognitions was associated with positive outcome, suggesting that exposure partly worked through cognitive change. Here I just wanted to briefly mention that exposure can now also be delivered via smartphone. Not so long ago, you needed quite specialized and expensive equipment to run virtual reality exposure. Today that has changed quite a bit. We now have studies using smartphone-based VR exposure and also augmented reality applications where a field stimuli can be integrated directly into the person's real environment, as you can see here on these pictures. And this makes exposure much more accessible and easier to integrate into everyday life, which again is promising for scaling up these interventions. But coming back to our randomized factorial trials, in summary, we identified 2 active components, psychoeducation and exposure. Whether or not these components were included in the treatment made a meaningful difference in terms of treatment outcome. In contrast, for cognitive restructuring and attention training, this was not the case. Including or excluding these components did not significantly affect treatment outcomes. This was just one example of a recent factorial trial looking at active components in internet interventions. More broadly, there have been several such studies in recent years, and if you're interested, Pim Kuipers and colleagues provide a nice overview of some factorial trials in a recent World Psychiatry article. There are also other approaches to identify which components actually work in internet interventions. I would like to mention a component network individual patient data meta-analysis on internet-based treatments for depression by Furukawa and colleagues. And again, an advantage of internet interventions for research is that they are highly structured and we know which components were included in each program and in each study. And Furukawa and colleagues took this one step further. They pooled the original data at the individual patient level across a large number of trials, and then they did not just compare whole treatment packages. Instead, they broke the studies down into which treatment components they included and then investigated how the presence or absence of each component was related to treatment outcomes across studies. And what they found is that behavioral activation stands out as the most effective component in internet interventions for depression, shown here in dark green. In contrast, components like relaxation were associated with smaller overall treatment effects. And I think this is really exciting because such studies may also enhance or advance our understanding of psychotherapy more broadly. Now, let me turn to the last part of my talk, the integration of internet interventions into routine care across countries. First of all, I want to highlight that implementing internet interventions in routine care is actually quite challenging. One of the key advantages of internet interventions is reach. Internet interventions allow us to reach more and often different people than traditional face-to-face treatments. And because they require less therapist time, they are inherently scalable. This means they have the potential for a substantial public health impact because, in simple terms, impact is a function of effectiveness multiplied by reach. So in this figure here, internet interventions are not primarily about moving to the right, improving effectiveness, but rather about moving upward by increasing reach and scalability. And I mean, almost every article on internet interventions starts by highlighting that with these interventions, more and other people can be reached. However, in practice, scaling up these interventions has proven to be much more difficult than we initially expected. Let me give you a concrete example. Sparks as a serious game. In Sparks, developed in New Zealand, CBT is delivered in a game-like format for adolescents, which makes it much more engaging and appealing for this age group. So this is a really interesting approach. Players create an avatar and navigate through a fantasy world, completing quests, solving puzzles, and interacting with characters while learning CBT skills along the way. Its effectiveness has been demonstrated in randomized controlled trials among adolescents with depressive symptoms, and based on this evidence, Sparks was rolled out nationwide in New Zealand in 2014 and made freely available to all adolescents. Recently, Fleming and colleagues published a study looking at what actually happened after Sparks was made freely available nationwide. And this slide summarizes the uptake. So over this period, more than 21,000 adolescents registered. That's about 2% of the entire age group in New Zealand. However, when you look at engagement, you see a clear drop off. About 58% actually started the program, around 11% completed at least 3 modules, and only about 2% made it all the way to the final module and completed the post-assessment. So the intervention works, but getting people to engage and stay in the program remained a major challenge in this case. And as a result, the public health impact I mentioned earlier is rather limited. Let me turn to another example and also on how internet interventions are implemented across countries. And I have to say there are quite substantial differences in how they are integrated into routine care in different countries. This example here is Germany, and several other countries such as France, Belgium are now following a similar model. As you probably know, since 2020, digital interventions can be prescribed by physicians and psychotherapists in Germany. These so-called DiGA, which stands for Digital Health Applications, are available on prescriptions to around 73 million people covered by statutory health insurance in Germany. These DiGA are listed in an official online directory, the so-called DiGA directory. To be included and reimbursed, these programs have to meet several requirements. This includes compliance with data protection and regulatory standards, good usability, and also evidence of a so-called positive healthcare effect. In practice, this typically means that at least one randomized controlled trial has to show that the DiGA leads to meaningful improvements, for example, in symptom reduction. However, also here, there are several reports now suggesting that the DiGA system is not yet a success. So far, prescription rates are still relatively low. In addition, according to this article here, around 20% of prescribed DiGAs are not even activated, and there is very limited data available on actual adherence and use. There are now several studies looking into reasons for the low uptake of DiGA, and they have identified a range of contributing factors. First, awareness is still limited. Many patients, but also clinicians, simply do not know about DiGA. Second, there is often a lack of training. Many clinicians do not yet feel confident in prescribing these apps or integrating them into their routine care. Third, administrative procedures can be quite complex, which creates additional barriers. And finally, there is still skepticism, specifically regarding the efficacy and data privacy. So overall, it's not a single issue, but rather a combination of factors that currently limits the uptake of DiGA. After discussing some of the challenges in implementation, I'd like to end with 2 examples of models that actually seem to work well and that are successful on a population level. A very prominent example is the IAPT program in the UK, now called NHS Talking Therapies. It follows a stepped care approach. Patients with, for instance, mild to moderate depression or anxiety symptoms typically start with low-intensity treatments, such as internet-based guided self-help, alongside other brief interventions. And if this low-intensity treatment is not sufficient, patients are stepped up to more intensive treatments like face-to-face therapy. And what makes this model successful is not only the structure, but also the way it is implemented. Outcomes are routinely monitored session by session using standardized measures, which allows clinicians to track progress very closely. And based on the data, the system itself is also continuously refined. So it's an ongoing learning system. I'm not from the UK, as you can hear, and may not know the system well enough, but I think that this combination, structured stepped care and routine outcome monitoring, is a key reason why this model has been successful and is now being implemented in other countries as well. A second successful example are so-called virtual clinics, which have been implemented in countries such as Sweden, Australia, Norway, Denmark, and Canada. These clinics primarily offer guided self-help treatments for common mental disorders, and importantly, they are very much rooted in research. In other words, treatments that have been shown to be effective in clinical trials have been systematically translated into routine care within these virtual clinics, within these services. Typically, the process starts with a diagnostic assessment, often conducted by phone or sometimes in person. And based on this assessment, patients are then offered an evidence-based guided self-help intervention. If you'd like to read more about these clinics, I would recommend an article by Nick Tito and colleagues in the journal Internet Interventions titled ICBT in Routine Care. And with this successful example, I would like to conclude my talk and thank you once again for the invitation.
Thomas, thank you so much for such an amazing, incredible talk. If anyone has questions, please feel free to unmute yourselves and ask. Write it in the chat, raise your hand, whatever you're most convenient doing.
All clear? No questions? That's fine.
Hi, Thomas. I have a question myself, actually. First of all, thank you very much for your presentation. And you got me thinking of a lot of stuff. So I'm going to see how I can formulate this question. At one point, you said that we shouldn't be comparing enter-based interventions to face-to-face treatments. And this might be one of the very few times that I've actually heard that. And that got me thinking, especially with how processes should be different, or at least they might look to be different in virtual interventions, how this impacts training. Should we be training therapists in a specific way to implement blended care treatments? Because, well, from what you showed us, it looks like blended care works better than any other combination of these. So how, and at first you also started speaking about the pandemic, and at that point, I remember it was therapists just sort of trying to implement it on their own. And how far have we actually come from that? Are we in a more organized and structured way of implementing it in our private practice, or are we still sort of just running into different resources that we try to implement on our own?
Thanks so much for this question. I think it depends a little bit on the country you're working. As I said, in Sweden or Australia or Canada, these treatments are much more common than, for instance, in Switzerland. But I think that we should include this in the training of psychotherapists. So I would agree with you, especially regarding blended treatments. Because we have to train the therapist how to use these self-help programs and how to integrate them into face-to-face psychotherapies. The most important problem with these treatments is adherence. So if, for instance, therapists just provide a self-help program to the patients, but do not talk about them in the face-to-face sessions, patients will probably not use them. And so we have to train the therapist how to use them in the face-to-face therapy sessions, how to combine them also with face-to-face treatment. So I would totally agree. And The current problem is that in many therapist training programs, this is not in the curriculum. So therapists are not trained in these approaches. I don't know if you asked several questions, I think, but maybe I answered some of them.
Yes, yes, you did, and perhaps a follow-up uh, question would be. I think it was very interesting what you said about the Germany DIGA system. Um, I don't think at least in Latin America that there is not something like that, and I think it really helps clinicians get a clear insight on how to distinguish the evidence-based apps and the ones that are sort of more a commercial use or more superficial. I mean, if I go into the app store of my phone, I will find so many interventions as a patient and as a therapist. So having this sort of support from official institutions. I think that helps a lot. Yeah.
Yeah, that's really an advantage to have such a directory, the DIGA directory. Also because there is research showing that the apps in the App Store are often not of very good quality and they are not evidence-based. So it's really good to have regulated apps. One of the problems we now face at the moment is that especially younger people are not using this DIGA anymore, but are just turning to ChatGPT. I think they use ChatGPT for all kind of stuff, for their studies, for work, and so on. Then it's easy to just also ask about emotional problems. And ChatGPT, of course, is not regulated. And this is a current development, I think, that we should observe also.
Thank you, Thomas.
There are also two questions in the chat. Grace, would you like to ask, or should we read your question? Okay, so I'll read it. Grace asked, how does this model apply to patients who think they're not experiencing psychiatric disorders and disregard psychotherapy?
So I'm not sure about this question. They are not experiencing psychiatric disorders, so they don't have a problem, or what?
I think the question was, how does this model apply to patients who are not fully aware or don't fully admit that they are experiencing psychiatric symptoms and they disregard psychotherapy, but we want to somehow help them and provide somewhat of an intervention.
Mhm. Maybe I can cite the literature on prevention of mental disorders here, because there are now also studies out, and we have also conducted two studies in the field of indicated prevention, in the sense that we targeted humans with increased symptoms, but not with a mental disorder. And what we could show in these studies is that we actually could prevent the onset of a full-blown diagnosis in the field of anxiety disorders and depression. So I didn't talk about it in my presentation, but these treatments also work especially in indicated prevention. Then the next question, how do clinicians assess whether a client is appropriate for an internet-based intervention? So I think the first question I would ask is about patient safety. That's the most important question for me. If a person is in an acute crisis, I think that internet-based treatments on a distance are simply not adequate. And the second question I would ask is about expectancy. I briefly talked about it, that positive expectations that this treatment will work is related with outcome. And if a patient does not believe that this treatment could help him or her, I wouldn't try it at all because it's quite a strong correlation between expectations and also outcome. But if the patient believes that this could work, I would start with it. And then, as a third step, I would observe how this person used the treatment, the program. We still have, after the start of a treatment, some patients who do not use these self-help programs. And then I would suggest a stepping up to a face-to-face treatment if they don't use it. That's the procedure we usually go through.
Maria, go ahead.
Okay, thank you. Thank you, Thomas, for your talk. It has been very interesting. I want to follow an idea that Juan Cruz introduced, this idea that you told us that we should not be comparing the in-person treatment effects with online-based interventions. Me and my colleague here, Maria Rita, we are in the couple therapy field. And as you may know, there are a few studies in this field of couples and family. We are trying to conduct a quasi-experimental study and collecting data for in-person couple therapy, internet-based couple therapy, and a wait list. But as it is a more ecologistic study, it has been very difficult to collect this kind of wait list group. So my question, or if you have a suggestion for us, how we present the result or how would be the best comparison with this kind of data from a realistic and naturalistic settings.
So maybe I could ask back. You couldn't randomize the participants
No,
into.
we have decided not to do it because in the 5 years ago, we conduct the first randomized control trial in Spanish-speaking populations. We are in Spain and in Latin America. And after that randomized control trial, we decided to conduct this more naturalistic study, like collecting data in a realistic setting of therapy, couple therapy. But now, as you say, we should not be comparing in person. So maybe we will have in the future three data sets, no, from waitlist, in person, and online. So what is the best to compare or to present?
Yeah, maybe I start by saying that I'm not totally against comparing face to face with online treatments. I just wanted to say that the advantage of internet intervention is to reach other people, and that's why we did not compare it. But it would be interesting to have large studies comparing the two treatments, also to find moderators in the sense that we could know more at the end for whom which kind of treatment would be adequate. And I think your study could also be very interesting in this sense. You could descriptively describe what happened in the two or three groups, and also try to use a matching approach, I think, and control to as much variables as you can when you compare the groups, as it was not randomized. That was my spontaneous idea now about your study.
Okay, thank you very much.
Thank you.
Well, I think there are no more comments or questions, and we are a little bit over time. So I would like to take the opportunity to thank you again, Thomas, for your amazing presentation and also our audience for listening in. I am going to paste again in the chat box all the information about SBR and where you will be able to find the recording about this talk, and also find more information about our in-person conference that's going to be in Osaka, Japan, with also the possibility to assist remotely. So I highly suggest everyone to look into it and keep an eye out for future events. I would like to thank you everyone once again, and I look forward to seeing all of you very soon.
Thank you again, and thanks for joining. And have a nice Eastern time. Bye.
Thank you. Bye.
All right, thank you.